Hey everyone, hi. It's me, Dr. Marty Ross again, and this is another one of our conversations with Marty Ross MD. For those of you that, oh, hi Alvin, it's good to see you. I just noticed you got your camera on there. That's great. So for those of you that are new to this format, and Rick, this is for you too. So the way that I work this format is I have people write questions to me using the chat box. And so you have to click on the chat box, write your question to me there, and then I work through the questions one at a time. I am not in this format, Rick and others, I'm not able to solve all of your healthcare problem. This is more to ask about short questions that give you more information. So this is not the same as a doctor's visit. And then, Rick, to answer your question, I don't do medical visits anymore. So I won't be able to set up a time to do one-on-one visit with you here either. Okay. So this is more just for everyone to sit and learn from each other's questions and come up with ideas that they might be able to share with their physicians as well too, or their healthcare providers. Okay. All right. So one thing I ask when you write your question, everyone, is make sure that you have sent it to everyone. That way, everyone can read it. And as we go through the questions, you can read along with me as I'm going through them as well too. All right. So I know we had about 100 people sign up here. We've only got about 18 here right now. We'll see what happens with this morning hour. As many of you know, the reason I offer this one time a month in the morning webinar is that I'm hoping to reach some of our European members and some of our members down in the Middle East as well too. So anyhow, that's why the timing here. Next week we will be going back to our regular time of 6 p.m. Central Standard Time for the webinar on next Thursday. Okay. All right. So without any further ado, let's go ahead and get started here. Oh, last thing, I am creating a recording again. And if it all goes well, that's the fingers crossed there. If it all goes well, I should have that posted up in the Zoom recordings area later this afternoon with a summary of what we talked about as well too. Okay, and as you all know, when you look at it in Zoom, there's little timestamp bubbles on the video that if you follow what I list that we talked about, they correspond to the timestamp bubbles in the video, so you can skip ahead to the part of the video you want to listen to again. All right. All right. So let's go ahead and get started here. This first question is from Trish. She says, "Hi, Dr. Ross. I'm off camera due to being at work. This question is about intramuscular antibiotics versus oral antibiotics and even the PICC line. What are your views on this? What is the best you have seen?" Okay. So Trish, it's a good question. So when I first started managing chronic Lyme disease, this would have been back in 2004. That was the first time I had a patient that had chronic Lyme. And that's kind of set me off on this whole path of working with people with chronic Lyme disease. But at that time, most of our thinking was influenced by the East Coast physicians, where there was a lot more of Lyme. And out on the East Coast at that time, everyone was claiming that the only way you could get better with Lyme was doing IV antibiotics. And so a lot of people, including myself, were doing IV antibiotics. But over time, they became what I call more the West Coast school of thought, which is orals do pretty good too. And why take the risk of doing IV or injectable antibiotics? All right. So now I think the majority of us over time, there has kind of been a meeting of the minds. And I think most of us use predominantly oral antibiotics with good outcomes, and occasionally we will do IV or injectable antibiotics. Okay, so I just want to give you that as an overview. The thinking has changed over time. All right. So what I see in terms of chances of success, if you look at oral antibiotics, you have about 85 to 90% chance that an oral antibiotic regimen or different oral antibiotic, like you try one, you try it for a while, it doesn't work, then you change to another oral antibiotic. Oral antibiotics have a chance of getting you well about 85 to 90% of the time. Okay, that's your success chance. Okay. And then IV and butt muscle IM injection antibiotics. The reason you do IM IV antibiotics is you get the drugs go directly into the blood, and they sometimes maybe even have a better job of getting into the brain. Okay, that's why you do the IV. And the IV antibiotics compared to oral have about a 90 to 95% chance of working. Okay, So what if you just heard what I just said, there's about a 5% increased chance that IV antibiotics will get you better. All right. Now, in my experience, there is no difference when you're using oral versus IV and the timeline that you're going to get better. So doing IV or doing butt muscle injections does not get you better faster. Okay. All right. The other problem you have to consider, yes, there is a slight 5% better chance you're going to get better with injectable antibiotics, but they come with huge, I'm going to say it again, huge risk. Okay. All right. And here's the issue. There's a huge financial risk because insurance companies still follow the old Infectious Disease Society of America guidelines that said 1 month and you should be well. And so they generally are good maybe at paying for a month of IV antibiotics, but they're not that good at paying for more than a month. Okay. So you have an out-of-pocket financial cost that you may get hit with on these. All right. All right. Secondly, because you're going to be needing to do these antibiotics daily on the IV side, that requires that you have some kind of a line, an IV line put in, and they're called PICC lines, where they go into the vein out here, sometimes up here, and sometimes they go into the big vein under your clavicle here. All right. And these PICC lines have a problem, and this is where it gets risky. One problem is they can get infected. Even though you try to use clean, sterile technique and you have clean bandages over where it goes through your arm, there is a risk that you get an infection into your bloodstream. All right, so there's risk of blood infection. The other risk is that the tip of this IV, whichever place you go in, either here or here or here, the tip of that IV sits in the big vein about right up in here, and there is a risk they can develop blood clots. And if you do get a blood clot at the tip of your IV, it can break off, float into the lungs, and we call that a pulmonary embolism, and it can kill you. All right. So I don't need to underestimate. There are these risks. Okay. All right. Now, if we look at over about a 6 month period of using IV antibiotics, well, probably a 3 month period of using IV antibiotics, about 15 to 20% of people will develop one of those complications. They're either going to get a blood clot or they're going to get an infection. All right. So that's a pretty high risk, right? For something that gives you maybe about a 5% better chance that it's going to work. Okay. So, where I had gone in my practice when I was still practicing, and I think many of you know I stopped clinical practice about 2.5 years ago. But where I came to is I was using IV antibiotics only when orals were not getting somebody well. And that might be about 6, 9 months in. If we were just getting nowhere, I might consider doing IV antibiotics at that time. Okay. And that's pretty much the only time I would do it. That would be if orals are not working. All right. Now, this question about IM, intramuscular antibiotics. All right. So, let's do this. So you can do IV antibiotics. You can come up with a regimen that will both address Lyme and Borrelia and Bartonella, doing IV. Okay. For butt muscle injections, though, we only have agents that are going to be effective against Borrelia. We do not have agents that are effective for butt muscle injections against Bartonella. So if you're going to want to go intravenous or get things directly into the blood, you're going to want to do IV. Okay, now butt muscle injections, IV antibiotics are two ways that things get into the blood directly. All right, so when you do a butt muscle injection, all of those antibiotics that in your butt muscle get absorbed quickly into the blood vessels. In the case of bicillin, which is a form of penicillin you can use, that bicillin actually leaves a deposit in your butt muscles that slowly is absorbed and picked up by your blood vessels over the course of about a week period, actually. And usually when we do bicillin injections, which is again is only going to be for Borrelia, we're going to do that about twice a week, actually, instead of daily. All right. So that's just my quick rundown. Trish, did that answer your question for you? So I know you're off camera. I assume you're going to be off mic here then too if you're at work. So anyhow, I hope that answered your question for you, Trish. All right, let's move on here. Oh, actually, does anyone else have a question about what I just said? All right, let's see here. Get rid of that. All right, next up is Jim. Hi, Jim. Good to see you here. Let's see. Hi, Dr. Ross. Thanks for these great webinars and thanks for all you do. I'm 1 month into methylene blue and Diflucan Bartonella protocol. What are some things I might consider adding to the protocol to make it more effective? Could you list them in order of importance? Sure. All right. So many of you may be aware that one of the Bartonella ways to treat Bartonella that I really love these days is the combination of methylene blue and the yeast medication called Diflucan, which we actually know is quite effective against Bartonella too. Okay. All right. All right. So, and I'll try to explain why I like it so much. First of all, it works well. People get good clearing of their thinking pretty quickly with it. And I'm tending to see good improvements overall when people do it. All right. So, how did we get the idea to use methylene blue and diflucan? Well, about 4 years ago now, researchers at Johns Hopkins University working in the laboratory found that we're looking for things to use for persister Bartonella and persister Borrelia. All right. So remember, the way Bartonella and Lyme work, Borrelia work, is that there's growing states of the germ and there's hibernating states of the germ. Majority are probably growing, but some get into these hibernating forms. And standard antibiotics don't really work that well against the hibernators. They're good against the growers. So we've been hunting, looking for what do we do about these persisters? Okay. And so in the lab, the researchers have been experimenting with a lot of things, trying to see what could they throw at persisters that would work. And they discovered that methylene blue is quite good against growing and persister Bartonella. And they found it to be good against persister Borrelia. They never researched to know whether it worked against growing Borrelia, though. I just want you to know that. But we think it does. Clinically, we think we get good results with it, okay? All right. They also then were looking at, in their experiments, they tested a member of every drug antibiotic antimicrobial family. So, for instance, they used doxycycline in their research instead of minocycline. And that was supposed to represent what the whole tetracycline family could do, all right? So there's a family of medicines called the azoles, and azoles are fluconazole, diflucan, itraconazole. All right, and they decided to use in their studies an azole called clotrimazole, which is actually is only made in a cream. It's not made in a pill form. And the reason, and it's not absorbed well, but they discovered that this azole, clotrimazole, did a really good job against killing growing and persister Bartonella. All right. We know from other studies it can be good against cyst Lyme as well too. All right. Now, because clotrimazole is not manufactured for absorption, it's only made in a cream. Many of us just kind of ignored that study, but about 5 years ago, maybe I'm sorry, 3 or 4 years ago, I went back and looked at that study and I thought, well, if clotrimazole is working as a cream, and you can only get it in cream, why not use another member of that family, which is either fluconazole or itraconazole? So that's where I came up with it. Okay, all right. So the one thing I like about methylene blue and diflucan, both of them treat growing and hibernating persister Bartonella. They also treat growing and persister Borrelia too. So if you happen to be treating both the Borrelia and Bartonella, you get that. Okay. The other added benefit about the methylene blue is it helps to break up biofilms found in Bartonella. Now, it may work on Borrelia biofilms too. We just don't know. The researchers only looked at biofilms in Bartonella, okay? So these days, when I look at some things that are blocking a Bartonella treatment, I want to make sure that I'm doing plenty of things to go after persisters, and this happens to have two agents that go after persisters, okay? Second thing I want to do is I want to make sure that I have a person on some good things to break up biofilms. So biofilms are a sugar slime layer that's held together in a protein matrix made up of fibrin, blood clotting protein. And it kind of covers these germs. It keeps the immune system out, it keeps your antibiotics out. All right. So there is starting to be a lot of microscopic evidence that these biofilms are pretty intense. So, in addition to using methylene blue here, Jim, to break up biofilms, I would consider getting on maybe one or two additional things. Okay. One is lumbrokinase. Lumbrokinase is an enzyme that comes from the skin of earthworms. I just, I love this crazy illness. We use earthworms to help you get better, but yes, it's enzymes from the skin of earthworms, and it's the strongest fibrinolytic fibrin breaker that we have in supplement form. Okay. And so that you could use that alone. If you break up the fibrin in these biofilms, they could fall apart. Coupled with methylene blue, you get double action there. All right. But in addition, I often will use, especially in people that are not getting better, having a hard time getting over Bartonella, I want to layer in another biofilm breaker on top of the lumbrokinase and the methylene blue. And what I like using is a product made by Research Nutritionals, which is called Biodisrupt. I'll show it to you here in a minute. Biodisrupt has one enzyme in it that can break up the fibrin. It's called serrapeptase. But again, it's a lot weaker than the lumbro. So even though it's got serrapeptase in it to break up fibrin, still use the lumbrokinase, okay? In addition, it has a number of herbs in it and enzymes in it that will help break down the mucousy part of the biofilm. And then finally, there's the herbs that are in it stop a number of other processes that make biofilms work. So it stops biofilms from adhering as easily. All right. It keeps them from sensing other biofilms. It's a process called quorum sensing, where one biofilm senses another biofilm when they try to grow together. It blocks quorum sensing. And then it also helps kill non-Bartonella germs that exist within biofilms. So biofilms are complex. They got these protein skeletons, they got this sugar, they have a bunch of bacteria that are non-tick-borne bacteria living in there that all have different functions. Like some of them operate like the post office, some of them are the sewage treatment facility. I mean, there's very elaborate things that happen in a biofilm. So to break them down, because I know they are such a huge thing in getting over Bartonella. If regular treatment in 4 to 6 months is not working, get aggressive about biofilms. Okay. All right. All right. Finally, Jim, the other thing I definitely would do is go after what are called fibrin nest. And fibrin nest are different than biofilms. All right. So yes, fibrin is found within a biofilm, but again, a biofilm is slime, bacterial colonies, bunch of other stuff going on in a biofilm. Okay. In addition, Bartonella can form what are called fibrin nest, which is Bartonella will wrap itself up in your blood clotting protein called fibrin, and these fibrin germ nests stick themselves on your blood vessel walls, and then the immune system can't get at it as easily either. Okay, all right. So you want to break that down. So lumbrokinase does that. So if I were to do more of a full court press in terms of getting your germs exposed so you can kill them better, I would, in addition to this methylene blue diflucan you're doing, Jim, I would consider Biodisrupt 2 pills twice a day. That's a product by Research Nutritionals. And I would consider lumbrokinase as a 16 or 20 milligram pill twice a day. The reason I said 16 or 20, there's one product out there called Beluki lumbrokinase. That's a 20 milligram pill. And then there's another product out there made by Allergy Research, which is a 16 milligram pill. My understanding is the Beluki has been held up at the Canadian border for a while. And so we're all, I think I'm still out of it. So at this point, the only thing you can really get, it's made in Canada, and maybe because of Trump warfare and everything else, it's being held at the border right now, the last time I looked. And but there's the allergy research product that's available too. Okay. All right. And then finally, Jim, one other thing to consider. So what I have just focused on right now is How do you kill the germs? How do you expose the germs so they get killed? Okay, all right. All right. There's a third factor that some of our members are finding helpful, and that is your we need to make sure that you're getting adequate blood flow to where these germs are hiding. All right. So there is your blood vessels. The inside of a blood vessel is made up of a type of cell called an endothelial cell. Okay, so the inner cells of a blood vessel are called endothelial cells. Those endothelial cells maintain a matrix on top of them that is called the endothelial glycocalyx. That endothelial glycocalyx is where nitric oxide is made. And nitric oxide, when it's made adequately by endothelial glycocalyx, causes your small blood vessels further downstream to stay dilated open. Okay, so you may be familiar in people with heart disease, we sometimes have them take nitric acid pills. All right, we do that because it dilates up the blood vessel. All right, so we know from COVID that in long COVID or in COVID in general, we know that there's science telling us that COVID destroyed the endothelial glycocalyx. And so in people with COVID, one reason they have all that brain fog and a lot of neurologic impairment is they just don't have adequate blood flow to their brain anymore. Okay. And I've been wondering for some time if the same process happens in Bartonella because Bartonella infects the endothelial cells. All right. It lives in those endothelial cells. And if it's infected them, there's a chance it does disturb their production and maintenance of the endothelial glycocalyx. Now, I will tell you, there's no research on this. I have talked to some of the best minds in this. I've done my own data search. I have talked to some of the best minds in the world of Bartonella. Dr. Breitschwat, who's the veterinarian that specializes in this, and Dr. Bozignani, many of you may know his name. I've talked to both of them. There is no research of anyone looking at this role of the endothelial glycocalyx and damage. But I have suggested to a number of people here in this forum that they may want to start trying to repair it. And some of them are reporting good results. All right, so what repairs the endothelial glycocalyx? What repairs the endothelial glycocalyx is a seaweed that is found in a product called arterisol. All right, and you start by taking 2 pills 3 times a day. You do that for a month, and after a month, you decrease it to 1 pill 3 times a day. And I would give it a 6-month trial to see if it makes any difference. Okay, all right. Now, I'm gonna open up for a question from you here in just a minute, Jim. But before I do that, let me just do a quick screen share here because I've said a lot of things here. Okay, so at my supplement store, the arterisol that I was just talking about. Okay, this is the product right here. Actually, I want to look at one thing here real quick. Yeah, actually, what I would do with this one, Jim, I would go start at 2 pills twice a day for a month and then decrease it to 1 pill twice a day after that. Okay. All right. So that's that product. And then in terms of the lumbar kinases, again, you've got 2 options from me. You can either get this allergy research, which I believe is the only one available right now. This one I think is still held up at the border, the Beluki. Hope to get it broken free soon, but it's not quite there yet. And then the BioDisrupt. This is the research nutritionals product called BioDisrupt. Okay. And then let me see here. There's one other thing I wanted to do. I believe in my article on how to get over Bartonella, I outlined some of this. Let me just go there real quick. So I do talk about using fibrin, biofilm and fibrin nest breakers, and I talk about the biodisrupt. I talk about lumbar kinase up here, okay? And then I do talk about repairing the endothelial glycocalyx, okay? So that's where you'll find the information there, okay? All right, let me go back here. All right, Jim, that was a mouthful. Did that answer your question for you?
That was really good. Thank you very much. I was wondering a couple of things. With the biodisrupt, do you know what's in that?
Yeah. Let's go back and look at it together again. I don't remember the whole list off the top of my head, but we can look at it. All right. So you've got a group of enzymes, of which serrapeptidase is serrapeptase, and that breaks up the protein. There's a few other protein breakers in here. The lipases, glucase, cellulases breaking up other parts of the matrix. And then it's got this cranberry, berberine, rosemary, and peppermint oil in it in small amounts, even though it says 605 milligram. Small amounts. Those oils are going to break up the other bacteria that are found within biofilms, okay? And in addition, these oils, certain ones of them stop this the swarming activity that happens with biofilm, stops the quorum sensing where they grow, and stops them being as sticky on the surfaces where they attach as well too.
Okay, are there any of those that are particularly important, or is it just kind of
I think this one, this is a product. I would probably do the whole product. They've done Research Nutritionals has done a study where they actually looked at the outcomes of laboratory research, looking at the effects of this. But it seemed it was important that it was beneficial at breaking down biofilms, but it was important that to attack the biofilm from all of these different directions. So everything in there would be quote unquote critical for it.
Okay, another quick question was my doctor was suggesting adding another antibiotic,
Yeah.
and she threw in the first thing she mentioned was rifampin,
Mhm.
and I told her I've tried that before and it made me really sick, so I
Yeah.
wasn't really keen on that one.
Yeah.
And other ones we mentioned were Biaxin and Zithromax. I don't
Mhm.
know, would any of that be helpful?
It could be. Sometimes, so if we look at the Johns Hopkins studies, asked a question, what other antibiotic could you combine with methylene blue to make it more effective? And in that study, they did not use clotrimazole. They did not put any of the azoles in it, okay? But in that study, of all the different combinations they came up with, the two strongest combinations were methylene blue with rifampin, and the other one was methylene blue with azithromycin. They did not study clarithromycin, and clarithromycin, azithromycin are substitutable. They're in the same drug family, basically. So
Okay.
either one of those could be a reasonable option to add to this.
And clarithromycin is Biaxin, right?
Yeah.
Okay. Okay. Would you add another antibiotic or would you just not?
I think you could. I think I would I found more results rather than adding a third antibiotic at this point at just getting strong at biofilms and and removing those fibrin nest. And then more recently, in working with some of the members through here, adding in that arterisol made some good improvements.
And the other thing is I have some biocidin just kicking around, a bottle that's not empty yet. Would it be worth emptying that?
You could use the biocidin instead of the biodisrupt. It also breaks down biofilms through a number of mechanisms. It doesn't have any of the enzymes in it though, but it can help block the what's called germ swarming, adhesion of the biofilms, and it inhibits the motility of biofilms. So it's another way of going at it. You could do that as a substitute until you get the biodisrupt.
Okay, good. Okay. Thanks a lot.
All
That's
right.
great.
All right. Good luck to you.
Thank you.
Does anyone else have a question about what Jim was asking about?
I do, if that's okay.
Yeah. Hi, Melissa.
Great. Hi. Thanks. First, as a longtime follower, thank you so much for your life-giving support and tremendous help. So very grateful.
You're welcome. Thank you. Thanks for saying
But
so.
I guess in connection with that, in addition to the cognitive dysfunction, do you think these damaged endothelial glycocalyx could also contribute, correlate with dysautonomia, including POTS?
Yeah, possibly so. So let me say a little bit more about the endothelial glycocalyx. So the endothelial glycocalyx, you've got your cell, your endothelial cell, all right, and then sitting on top of it is the endothelial glycocalyx. It's kind of a sugary substance, and it's got a bunch of hair fibers that stick up through it. And the action of blood flowing over these hair fibers triggers nitric oxide to be made. Okay. All right. So now if you've got it, so any nerve in the body, any part of the brain and the nervous system could be affected by lack of blood flow. So in terms of dysautonomia and in terms of POTS, which is part of dysautonomia, what we think happened, one of the things that can happen is your vagus nerve, which is a nerve that comes off the back of the head that is responsible for regulating adrenaline and anti-adrenaline production, which is what's out of whack when you have dysautonomia. So you can get dysautonomia because the germs directly infect the nerve. Okay, so either Bartonella can do that, Borrelia can do that. Okay, all right. But the other thing that could be happening is because of Bartonella, you could have limited blood flow going to the vagal nerve and the distal, the distant reaches, small parts of the nerve, and so you could have some dysfunction from that too. POTS and dysautonomia are big within long COVID. There is the protocol that has had some limited research that I have on my website that say to give a try says, yeah, give a 3-month trial of repairing your endothelial glycocalyx. And people do report a lot of improvements in their POTS and dysautonomia symptoms when they do that. Keep in mind that protocol, you could Google it out, just not Google it, but go to the treatlyme.net site, just write long COVID, you'll find my protocol. Okay, one part of it is fixing the endothelial glycocalyx, but as one part of that protocol, people get a lot of correcting of the POTS and the dysautonomia that they have.
Oh, that's tremendous. Thank you. Would you recommend anything about the nitrous oxide? You mentioned either, was it a medication or a supplement to reduce that?
The problem with nitric oxide, so you can find there's like supplement manufacturers that make nitric oxide tablets. You probably have seen these commercials for Beets, the little chew tablets that you chew. That the reason you're doing that is they're pulling a lot of nitric oxide out of the beets, right? The trouble is with all of those ways of supplementing is they're extremely short acting. It's a one and done. You take it, has its immediate effect, and then it's gone. Even in the case of when we have people take nitroglycerin sublingual under their tongue when they have chest pain, it's only to give a temporary dilation of that blood vessel to increase blood flow back to the heart. All right, it doesn't last long, and so probably the better way of going is fixing the mechanism that leads to the nitric oxide production.
Great. Thank you so much.
All right. Good luck to you.
Thank you.
All right. Let's see here. All right. Hello, Lee. Let's see. I have mold, mast cell activation syndrome in POTS. Per your suggestion, I read your yeast overgrowth article and the supplements just arrived, not started yet. The problem being is that I have developed a case of GERD that started at the beginning of February and keeps getting worse. It seems like when I try to treat it with Pepcid, etc., I get more reflux. I have made all the necessary lifestyle adjustments, elevated bed, no spicy foods, sleep on left side. Any idea what might be going on here or suggestions? Lee. All right. So Lee, are you, let me see where you are there. Lee, are you here actually?
Yes. Hi, Dr. Ross.
Oh, there you are. Hey, Lee, can you tell me what, a couple things. And if, I'm sorry if some of this goes personal, but I need the information to kind of gather. Okay. How many cups of coffee do you have a day?
2 cups of decaf in the morning.
It's decaf though.
Yeah.
Okay. Caffeine can trigger reflux too. That's why I'm asking. Much alcohol at all?
None.
Okay.
Well, except for in tinctures, but
It's small amounts. Okay.
Right.
And then what prescription and herbal medicines are you on at this point then?
Oh wow. Okay. Let's see. Turmeric. Isocucertin, milk thistle. It's pretty much like a detox protocol.
Okay.
As far as herbs, the only thing I'm kind of dabbling with at the moment is the CSA combination. I'm going to butcher this quick. Ceta, Cuta, and Alcornia, I believe.
Okay. Okay. Here's some thoughts for you. So of what you, the reason I was asking, I'm trying to figure out, is there something you're taking that's triggering the
Oh,
reflux? Okay. All right. All right. And so, a couple things you might want to try. So one, the alcohol-based tinctures in some people can make the reflux worse. Okay. And so what you can do to limit that effect is as part of taking boil water, pour about 1-2 ounces into a cup of water. Instead of taking your drops directly, drop them into this boiled water. And what's going to happen is not all, but a lot of the alcohol is going to steam off. And as that cools, then you drink it. So you can put all of your alcohol tinctures in the same 2 ounces of water, just drink it all together at once, but steam off some of that alcohol, because that will be less irritating to the skin that lines the valve between your stomach and your food pipe. Okay, I'll say more about that in a minute. All right. Second thing you might.
Oh, sorry. I was just going to say the CSA I switched to the glycerite, and I'm only taking 5 drops a day, so I just put that in there. Okay, sorry.
Okay, all right. So then that may not be an issue. The other thing you might want to try is, have you tried any licorice at all?
Yeah, I'm doing licorice, marshmallow root, and aloe.
You are. Interesting. And then I'll throw another thing at you, but you would need to talk to a functional medicine doctor about this. Sometimes reflux is, the symptoms of reflux are caused by low stomach acid, not high stomach acid.
That's kind of what I was thinking when I was doing, some research on it, because it seems like even when I try test, and I did that baking soda HCl test. I don't know if and it was, I think the goal is between 3 and 5 minutes for your first burp, if you will, and I'm somewhere around 10 or 15 minutes.
Yeah.
That's interesting. Okay.
So you could, if that,
you
might want to talk to your doctor about it, but you could add in something called betaine, which would help elevate the stomach acid and see if that will make a difference. But I would talk with your doc about that first.
And I was tested for the H. pylori, and that was negative.
But if everything is not working, sometimes we need to look inside the stomach and just make sure that it's all reflux and not something else going on too.
Okay, good. Yeah, I'm supposed to have another upper endoscopy in about a month, but they're like, "We'll take a bunch of samples." I'm like, "Oh, please no."
Yeah. No, I get it. But you may want to look at the possibility of betaine, but I would again run it by your doctors first and see what they think about that.
Gotcha. Is there any kind of a test for that stomach acid, or is it just a give it a whirl? And
I believe there is. I haven't done it though.
Oh.
I never had I'm aware of this, but I never had a situation with a patient of mine where I had to go through the next process and actually start trying to diagnose to give them betaine. So unfortunately, I'm not the good source on that one.
Okay.
Great. All right.
Well, thank you very much for your time.
Okay. Emily, I think I see your hand up there.
Yeah, I wanted to ask, do you know anything about zinc carnosine for helping with the acid?
Remotely, not enough to talk about it.
Okay. All right.
I know it's on the list of things that integrative functional medicine providers will try if other things are not working. And believe it or not, I never had to go down to that level. Usually,
yeah, absolutely.
Usually just adjusting the tinctures and getting people off of things that cause it, and having them take licorice has always worked in my practice for me. So yeah.
The DGL?
Yeah.
Okay.
Yeah.
Okay, because I'm having similar issues to what was just discussed, so I figured I'd pop in. Cool. Thanks.
Good luck to you.
Thanks.
Did anyone else have a question about? Oh, Sylvia, I think I see your hand up there.
Yes, hi.
Hi.
First of all, I wanted to say hi because first time on video. Thank you for the European times.
Where are you located over there?
I'm in London, in the UK.
Okay, good.
So I've watched you at 12 o'clock at night here, half asleep in my bed. So
good to be awake for once, right?
Yeah. I just wanted to add, I also have low stomach acid, and yes, there is a test for it because I've tested and I know that it's low. And yeah, what you suggest is something that I need to get myself as well, but there is a test. I just wanted to.
Okay, so your docs over there are able to do a test. And I
Yeah,
think
I think
there may be, again, it's not one of those things I've had to do before, so I can't speak to it off the top of my head, but I believe there is one. So yeah.
yeah, there is. Yeah, just wanted to add that. So
Oh,
yeah.
good. Thank you for letting us all know that. And welcome here.
Thank you.
All right.
All right.
You know, I'm keenly aware of the time difference. My daughter lives in London right now, so
Oh, okay.
so yeah, so it's early evening for you. Well,
Yeah, it's 5 p.m. almost.
yeah,
So
early
it's a nice time to do this.
Yeah. All right. Good.
Thank you.
All right. All right. Let's move on here. Let's see. Hello, Melissa. Let's see. Have you observed severe sudden onset psych symptoms during a BART relapse resembling bipolar or schizophrenia? How can you differentiate between a BART relapse and mental illness, as well as determine if the psych symptoms are temporary? After 18 months of treatment for Lyme, BART, tick-borne relapsing fever, anaplasmosis, using your protocol and recommended medications, herbal treatments, rotated every 3 to 4 months, I was about 75% through treatment. 9 weeks after a difficult out-of-state move with sleep deprivation, I caught a cold, triggering dysautonomia flare. Mild pancreatitis. 2 weeks later, I had severe psychiatric symptoms of insomnia, paranoia, anxiety, rage, panic attacks, interpersonal sensitivity, cognitive suicidal thoughts, depression resembling bipolar 1, but didn't really fully align with DSM-5. I was treated with lithium, which was discontinued, and Lamictal 150 milligrams maintained. I took a break from Lyme treatment to stabilize later skin lesions consistent with bacillary angiomatosis pointed to a BART relapse. Bear with me. I'm going to answer your question. I just want to look at one point here real quick. All right. So whenever there is severe psychiatric issues, we always think Bartonella. We just do. Okay. The problem is we don't have a way of testing for sure to say, aha, your psychiatric flare is Bartonella, or your psychiatric flare is a flare of an underlying psychiatric illness that has nothing to do with Bartonella. We just don't have a way of testing for that, okay? But most of us assume, especially with what you've outlined here, that yeah, you've got to consider Bartonella, especially if you've been diagnosed with it before. Now, the only thing I would throw in here, Melissa, and I can't remember if when I was still writing responses to people's questions in Lyme United, if you wrote something about this before or not, but you know, one thing that you just to consider, okay, and it may seem kind of far-fetched when I'm about ready to say, given how severe this got, but whenever there is a big decline after you've been doing better, you've got to make sure there isn't intestinal yeast overgrowth. And you may be thinking, what the hell does that have to do with my psychiatric symptoms? So just hear me out on this, okay? So in Bartonella, one of the major causes of your symptoms is the germ triggers an excess production of cytokines, all right? And cytokines are chemicals made by white blood cells, are good and bad. On the good side, white blood cells make them to attack a germ, turn the immune system on, cause more white blood cells to be made, and draw those white blood cells to where the infection is, all right? However, in excess, if the immune system's not doing a good job, or if something else triggers more cytokines to be made, like intestinal yeast overgrowth, that can trigger a whole host of problems, of which psychiatric symptoms are big on the list, okay? Other things that can get triggered with excess cytokines are more body pain, more difficult thinking, sleep disturbances, you name it, okay? Any of those can do it, all right? Now, the things that would be a setup, so why am I saying intestinal yeast? Well, having been on all these antibiotics, you're a setup for getting too many intestinal yeast. Even if you've done great things with probiotics, you've been on Diflucan, you've taken nystatin, whatever you're doing to control yeast, you are still a huge setup for getting too many intestinal yeast. And so what I have found in my practice is when people are doing better and there's a big decline, about 80% of the time, it turns out to be intestinal yeast overgrowth. All right. So questions to ask to help figure that out are, did you have any increased sugar cravings? Did you do a big sugar binge right before this happened, to kind of calm all the anxiety from your big moves and everything? Were you having a lot of cookie, candy, cake, ice cream, for instance? Did you feed yeast? All right. Other symptoms to look at is if you do have sugar, do you get a lot worse for it? Do you feel a lot more fatigued? Do you have a lot of intestinal gasiness or bloating? Have you had more skin manifestations? Do you get more eczema? Do you have more pimples or acne? They seem to get worse whenever you have intestinal yeast overgrowth. And if you're a woman, are you having increased itchy vaginal discharges? Okay. So if you said yes to a number of those, I would be looking at possibly treating for intestinal yeast overgrowth as well too. All right. So Melissa, are you still there?
I am. Yes.
Yeah. Yeah. So, oh, that was you. All right. Got it.
Yes. Sorry.
Is it possible it's yeast?
It could be. My doctor, I'm on a near sugar-free, like basically zero sugar diet. I mean, I do have some of those symptoms. We originally thought it was a Lyme relapse, and I went on fluconazole, which I was also on earlier, and
Yeah.
it was mixed with an antibiotic. I can't remember off the top of my head which one, but
Yeah.
that is one thing I haven't considered well. I
Yeah.
occasionally take a Candida supplement with some of those, and I'll go back to that.
You might want to do that. I mean, you could, if I was treating you and I wanted to still make sure I'm covering for Bartonella at the same time and doing something that can get at yeast, what I would look at doing in a situation, well, I'm sorry, I'll say it and then I'm going to clarify it. So I would do a methylene blue with an itraconazole or fluconazole. The trouble is, if you're on a number of psych medicines, you may not be able to do the methylene blue.
Just a lamotrigine, mood stabilizer.
You might be able to do. Let me look something up because I'm trying to remember. I'm not clear if it's on the list of things that can increase serotonin or not. Bear with
I
me.
will
I'm
also
looking at-
mention, I have a question a few down related. Once we realized it was the BART relapse, I went on rifabutin, clarithromycin, the oregano oil, cinnamon clove, as
Yeah.
well as some tinctures. And the psych symptoms really reduced tremendously going
Okay.
on those.
So that
But-
might have helped. Yeah. I'm still trying to decide, could yeast have been the initial trigger though?
I see. Okay.
Yeah. Bear with me. I'm just looking something up about Lamictal here. I'm in my drug directory here.
So it's lamotrigine, not, well, maybe that's the same. I guess
It's
that's the
it's
same drug.
generic. Yeah.
Sorry,
It's the
yes,
generic.
you're right.
Yeah. No, it's okay. I should talk in the same terms. Lamictal is the non-generic version.
Yes.
Yeah. All right.
I connected that. Sorry.
Let's see here. Pharmacology. Yeah, I think from what I can see here, I think you'd be okay using methylene blue with it.
Okay. Then a
So, and
question
the
regarding that.
reason I'm saying that is the methylene blue of all the prescription antibiotics is probably going to have the smallest chance of knocking down good bacteria in your intestines, because knocking down good bacteria triggers more yeast, right? And the itraconazole, as I mentioned earlier today, the azoles are quite effective at treating Bartonella too. So the itraconazole would help your Bartonella, methylene blue would help your Bartonella with limited chance of knocking down good bacteria in your intestines. Itraconazole would go after your yeast in your intestines. And if you've in the past have used fluconazole but didn't have good improvement doing that, sometimes that means the yeast are learning resistance to fluconazole, but that doesn't mean they will be to itraconazole. All right. So it's just something to consider with your doc, basically.
Sure. So sadly, my doc, MD with a private practice, has just been hospitalized and is probably not going to recover. So is there a way to purchase methylene blue without the prescription from the compounding pharmacy?
That's hard. And so no, there's not. And so the problem with methylene blue is you can find methylene blue on the internet, right? But keep in mind, methylene blue on the internet is being made from clothing dye. Methylene blue is sold as clothing dye. Methylene blue is sold as something to clean your fish tanks. The problem with those powders and liquids you get online is they may not have been adequately tested for heavy metals. That's the issue, is a lot of the stuff you get online. You could get it online, but a lot of the stuff may not be clean.
Would you feel more comfortable using an online supplement that has third-party testing available?
If I was to do methylene blue online, I would make them send me the certificate for the batch.
Okay, great.
Yeah, yeah. All right.
Thank you very much. Appreciate
Yeah.
it.
You're welcome. Good luck. All right. Does anyone have any follow-up question to what we were just talking about with Melissa? All right. Let's see.
Gee, I have a question.
Sure, Marcel.
Yes, hi there. Testing for intestinal yeast, is there a test you would recommend?
Yeah.
Confirm the
No.
diagnosis?
No, and here's why. Let me tell you what tests could be available. Okay, so you could get a stool study done where they try to quantitate whether you have extra yeast in your intestines or not. Okay, so you can get a stool test. The other way that some doctors will test for it is to do an antibody test to see if you're making IgG. Excuse me, whether your blood is making a family of antibodies called IgG antibodies. All right, so those are generally the two ways. The problem with that is on the IgG test is all of us have yeast that live in our intestines. So as part of our body controlling yeast, it's not unthinkable that we would all have some degree of IgG. Not everyone does, but some people do. Okay, so that doesn't tell you whether it's yeast that has grown too much, all right? And then the problem with the stool test is, although they're gonna say that relative to an average person, you have excess yeast or you don't have any yeast, it's all being said relative to a normal group of people, however you define normal, right? And what the issue is, isn't what's happening with your yeast relative to other people, it's what's happened to the quantity of yeast relative to what's your normal. And we have no way of knowing that from doing a random stool sample, right? So what I have found more predictive is if you've never treated yeast, on my, I'll show you the article here in a minute. I have an article where there's a questionnaire. If you've never treated yeast, there's a questionnaire you can fill out that looks at risk factors for yeast and symptoms of yeast. And if you score high enough, I have found 99% of the time treating yeast makes a big difference. Okay. All right. Now, that questionnaire is not as relevant if you've treated yeast before, because treating kind of resets some of the yes questions that you've had there before. So usually what I'll do is, if you've treated yeast before, I'm always going to focus on, have you had any skin outbreaks like I suggested earlier? More sugar cravings. Do you get worse when you have yeast? I'm sorry, do you get worse when you have sugar? Intestinal gassiness and bloating. And in females, whether they got vaginal itching, vaginal discharge. Okay. Let me show you the article in case you're not familiar with it here. Okay, so this is back at my information site, and I have a yeast section in my treatment guide, and then it's this article called "A Silent Problem: Is It Yeast?" And then within here, here is the link to the yeast questionnaire, all right? But again, if you're in the middle of treatment, you want to focus not on the questionnaire. And if you're in the middle of treatment and you have treated yeast before, you want to focus on this list of symptoms right here, whether you have a number of these or not, okay? All right. Thanks for the question.
Could I ask a follow-up one?
Yeah, Melissa. Yeah.
A quick one first. Is it okay to continue the herbal tinctures with the methylene blue and fluconazole?
Yeah.
Okay. And then would you consider mold testing despite no known exposure? And I just took a VCS test that I passed with flying colors.
Oh, okay. So if I'm treating a patient that the time I'm going to start thinking about doing mold toxicity testing is in two situations. Number one, when a person first comes to see me and they already have Lyme testing that's positive, but I take a detailed history and I find out that they got sick when they moved into the house that had the black mold on the wall, I'm not going to treat tick-borne infections. I'm going to find out whether they actually have mold toxicity by doing a urine test, okay? Because sometimes they can look the same, and even though you have a positive Lyme test, it may your immune system could have dealt with Lyme, and your real issue could be mold. So, all right, the second time, so I will test for mold toxins at the beginning of a treatment if the story says, boy, I better really think that this could be yeast, okay? All right. The second time I go testing for mold toxins is if I've got somebody that we're like a year, 9 months, a year into treatment, and we're just making no headway. I'm going to start wondering, what am I missing? What is masquerading as something that looks like tick-borne infections? And that's kind of a situation I would go and test for mold toxicity at that point.
Okay, and what's the primary urine test, the lab?
I like using a lab out of Texas here called Real Time Lab.
Okay, great, thank you.
Yeah. They seem to have the more accurate urine testing method. And I don't know whether you saw, Melissa, I don't know if you're on my email list for my Treat Lyme by Marty Ross MD site, but if you are, I sent out a newsletter yesterday. I'm calling the Tick Craft newsletter. And in there, I walk the beginning article that I outline in there is what are the tests and which one's best for mold toxicity.
Oh,
So
okay,
take a
I
look
did
at
not
that.
get that. Is there a way to access that without?
Let me see here. Bear with me. I'll show it to you here. So first of all, if you want to get them in the future, just go all the way down to the bottom and just put your email in here. You'll be subscribed to my email newsletter in the future. Okay.
Okay.
All right. And I'm in the process of having both my information site and store brought together, and on that news site there's going to be a page devoted just to signing up for the newsletter. I don't have that yet. Okay, but in terms of where else you could go, let's see here. Tell you what, oh, how can I do this easily? Let me see. Okay, I'm going to drop it into the chat box, but on the recorded version, you might be able to see it here. This is my sign up page for my newsletter. Okay. And if you want to see what the latest version looks like, you would just go
Okay.
here and you could click there. And that's the latest copy of my newsletter.
Okay, great. Thank you very much.
Right.
Appreciate that.
So what I'll do, I'll put the URL in for the newsletter into the chat box so you all can see that. Okay. But the first part of this is urine test is best. And I walk through all the different ways you can test for mold toxicity on that. Okay.
Great. Thank you very much.
All right. And let me see here. So I'm just going to put this. I'm putting the URL into the chat. And so it will be the last chat entry that anyone just made. That's the URL for it. Okay.
Okay, thank you.
All right. Okay, let's see here. Hello, Aliska. Let's see, would it be possible to add this product to your esophageal, please? Microbiome Labs Mega. Let me look into that. I got to see if I think I would have enough interest in other people buying it, but I can take a look at that for you. Okay.
Oh, thank you very much.
Yeah, you're welcome. Let's see here.
Can I just actually add, since we're on the topic of Candida and yeast, can I just ask? So my daughter has been tested, but it was a blood test, and her EGM and IgA are negative. The lab came back saying that it's a slightly elevated EGG for Candida.
Yeah.
But she's 9 years old. She's going to be 10 soon, though. And she has been on not a zero sugar diet, but a low sugar diet. So like she's no sweets or chocolates or anything like that. But when I make, let's say, a homemade muffin, like she would have one during the weekend. Like during the week, it's strictly nothing, not even a fruit. But when it doesn't happen every time, but sometimes it happens. Like the other day, we went for a birthday party and she had a piece of cake. And then she said that she feels sick or nauseous in her throat, and that she feels something that she can't really put her finger on it or describe it well as a child to me, but she's saying that she doesn't feel well after eating something with sugar, but it's in her throat. She doesn't have any problem with her bowels. They're regular every day, twice a day. There are no issues, no diarrhea or anything like that, no constipation. She is not complaining about anything else really in regards to Candida, but she does tell me this thing. And I wonder, can this be Bartonella? Because she does have Anaplasma, Bartonella, and Lyme. Or is this Candida? Or is this something completely different that I'm not even aware of?
Boy, I don't know.
Okay.
Yeah,
Okay.
I'm sorry for what you just described there. I can't tell.
Yeah.
I probably need to ask her a lot more questions, but I can't figure that out right here.
Okay. Okay. No, that's fair enough, Dr. Ross. No, thank you very much. It's just because she's been saying it, I was just wondering if anybody else had the same experience or if you heard about it.
Yeah,
Okay.
I mean, the one thing, sometimes people with intestinal or yeast overgrowth will also have yeast in the food pipe, right? But usually that's going to be a symptom that I have seen of people feel like when they're swallowing, things start feel like they're catching as they swallow down. But I haven't had that kind of symptom that you're describing.
Right. Okay. Okay. Yeah, no worries. Thank you very much.
You're welcome. All right, let's see. Cindy, I see your hand up here. Cindy Grove.
Yes, thank you.
Yeah.
Along the lines of the methylene blue, I've had long COVID since 2020. And so it's been a long stretch. Right now I'm doing hyperbaric chamber sessions weekly, 25 milligrams of methylene blue, 6 milligrams of the low dose naltrexone, and have added glutathione. When I added the glutathione, a possible type of like Herx reaction, and I just felt really flu-like, really sick. And so, but I was wondering as I'm going through this process, which does seem to be actually doing something. So thank you, Dr. Ross, for putting your information out there. Are there ways that I can support my body, or things that I can do to, or things I should be avoiding while kind of going through this process?
So the one thing about the methylene blue, or I'm sorry, the glutathione. So there is a couple things that could be happening here with that. Number one, it may be that it's detoxing you too quickly. So the glutathione could be doing two things. It's a strong antioxidant that will lower oxidation agents that are telling your white blood cells to make cytokines. All right. So long COVID has excess cytokines. So on the one hand, it should be helping to lower cytokines. Okay. However, if you have the other thing that glutathione does is it's the main detox chemical that is used in every one of your cells to intracellular detox, but also it's used by your liver to detox. All right. Now, if as a result of having COVID, you have depleted some of your glutathione stores in your cells, and what will have happened is you've got a buildup of toxins sitting behind this roadblock because there isn't enough stuff to detox them, right? And so now you start giving your liver what it needs to detox, and this barrier comes down, and all those toxins come rushing through. And so the movement of toxins, basically out of stored tissues into the bloodstream, can trigger a cytokine flare. So what I would suggest doing, I don't know, what did you use for your glutathione? How much did you take?
Probably a little too much at first. A teaspoon, I think it was, or a little bit less than a teaspoon. And it's that squeeze kind in the bottle there.
Yeah. So what I would do is probably start at a quarter of that. The next time you take it, take a quarter and see what happens. Okay. All right. Then There's a small group of people with glutathione that have, I think it's sulfite sensitivity or sulfite issues with glutathione. And if you have a sulfite issue, oh, darn it. Albin, are you still with us? Albin will know this. There's if you have a sulfite issue, I forget it's mangan or something.
Sorry. Yeah, I'm here. I was doing
Albin,
something else.
Albin, I'm blanking.
It's
What is it?
molybdenum.
Molybdenum. Molybdenum.
Yeah.
That's right. Molybdenum.
Molybdenum. Yeah, exactly.
Right.
I don't know the pronunciation, but yeah.
Do you know what the doses they recommend on that?
I don't remember, but I think it's 200 to 500 milligrams or something like this. But
That's right. That's right.
yeah.
So
Okay.
there are people that have sulfite sensitivity issues that worsen with glutathione. And I'm not remembering the exact mechanism, but if you continue to react even at small doses, consider adding in molybdenum, 200 to 500 microgram, I think milligrams a day. Whatever you'll see, whatever they manufacture it is, it's usually, I think it's milligrams if I'm right, but one a day, and see if that will make a difference for you too. Okay.
Thank you.
Yeah. Yeah. All right. Thanks, Albin. I appreciate the backup. All right. Let's see here. Ed W. Let's see. I've developed a case of lower GI irritable bowel syndrome last 5 weeks. Never had this before in my life. If this is a manifestation of my infection, is there any other herbal antibiotics consideration aside from typical IBS foods? Detox considerations. Currently on small biocidin dose, glutathione, Cytoquil, ashwagandha, NAC. Have appointment with the antibiotic doc as plan B. All right. So whenever I see a worsening of any kind of symptoms of intestinal gasiness, bloating, cramping, the first thing I think of is it too many yeast triggering those symptoms? And so, Ed, I know we've talked about that a number of times here already, but you might want to look at, again, my article about how do you diagnose yeast. I showed that earlier. If you say yes to a lot of those symptoms, I would handle this probably until you see your antibiotic doctor as too many yeast and work on a probiotic regimen as well as something to kill those yeast. Now, I will tell you the biocidin you're on can kill yeast. It doesn't always work effectively. So you might want to look at some of the other options that I have for that too. All right. So I know we've talked about yeast here again, so I'm kind of being short with you so I can move into some of the other questions, but that's probably where I would go.
Okay. I don't think it's yeast. I don't have really any of those symptoms.
Okay.
And if I can quickly just tell you how this came about, it seemed like it was a stomach virus, 3 days, went away. Then a week later, it came back for about a week. Then it went away, and then it came back, and it's kind of here to stay. Doctors put me on an antispasmodic and Augmentin, which is helping considerably.
Okay.
But I'm pretty nervous about this because this was a turn I was not expecting, and
okay.
Let me
give you another thought then.
Yeah.
So when you get viral infections, for instance, COVID is notorious for this, but viruses can dramatically impact the gut microbiome, disturbing the balance of good bacteria. And as you know, it's the balance of good bacteria that ultimately keep your microbiome in your intestines functioning well. Okay.
Sure.
So in a situation like this, what I would probably try what are you doing in the way of probiotics right now?
So I take a probiotic, mostly vegan, a lot of fiber, and all of the live cultures, tempeh, cottage cheese, kombucha, on and on and on, pickles.
Okay.
Really, I'm aware of all this, and I'm trying to do. I'm doing the FODMAP diet. I'm kind of trying to do everything here,
You're already doing everything I would do.
Okay.
I won't. I mean, obviously, I would. If I had more time, I would talk with you a bit more.
Okay.
But you're doing what I would consider the right things. For
Yeah.
those of you that are listening, and this idea that I said that after viruses you can get a lot of GI symptoms, what I usually would have people do in this situation is start a probiotic called Metabolic Daily by Pendulum, and the Metabolic Daily has. The main probiotic in it is called Akkermansia. And in addition, it has 4 different strains of bacteria that, working with their Akkermansia, lead to greater production of butyrate. So butyrate is a small chain fatty acid that is the main fuel source for your intestinal and your colon cells. And if you give more of a good fuel source, those cells will work better. And also, if those cells have pulled apart and you've developed leaky gut, it helps those cells heal back together again too. So I'm usually wanting a probiotic that will also be a butyrate producer for somebody as well too. Okay, so yeah.
Marty, really quick. Thank you for everything you do. You have a beautiful soul, my friend.
Thank you. I appreciate you saying that. Thank you. All right. All right. Let's see here. Hello, Lisa. Let's see. Would you advise adding another killing agent to azithromycin, Malarone, and Aracoda for the treatment of Babesia and tick-borne relapsing fever? Also, could you advise when to add lumbar kinase in the treatment plan? Many thanks. All right. So, Lisa, I think that the regimen, no, oh, there you are. Okay, I knew I saw you here earlier. So, you're on a good prescription regimen. That azithromycin, Aracoda, everyone is tafenoquine, and Malarone. That's a very comprehensive regimen in terms of germ killer. The next place I would go in terms of trying to make some progress here is get the lumbar kinase going. So, everyone, as you all know, I talked about Bartonella fibrin nest. Well, Babesia also can form fibrin nest too. And so sometimes the reason people have a hard time getting over their Babesia is that some of the germs are still wrapped up in these fibrin nest, and even the good antimicrobials I think it's your daughter, if I remember correctly, is on, Lisa, just can't get at all the germs. So I think before I would add in another germ killer like the Cryptolepis, I would start stripping out those fibrin nests. I would start at 16 to 20 milligram pill a day. And as she can, because she's probably going to get a herx from that, then try to go up to 1 pill twice a day on that. Okay.
Thank you so much. And I just want to say again, thank you for everything that you do.
You're welcome. You're welcome.
You mean a lot to this community.
Yeah. I'm sorry I've had to pull back, but I think y'all.
No. I'm glad you went to that retreat. It seems like it provided you with some clarity.
Oh, it did.
Oh.
Yeah,
We'll be okay. We'll be okay.
All right.
Thank you.
Thanks, Lisa. I appreciate that. Yeah. All right. Let's see here. So, hi, Marcel again. Let's see. What are your thoughts about methylene blue, ivermectin, red light therapy, hyperbaric oxygen therapy? Thank you for what you do. All right. So methylene blue, as I had suggested earlier, I didn't suggest entirely. So we like it for Bartonella, Borrelia. It's a good germ killer for those, okay? Number 2, it breaks apart biofilm in Bartonella. Number 3, it helps improve, it does a rapid patch to injured mitochondria. So in chronic infections, you sometimes get injury to your mitochondria. Methylene blue doesn't permanently fix that injury, but it can do a quick patch. So you can sometimes get better energy, you get better thinking pretty quickly by being on it, okay? Other things that methylene blue does is it's known as an MAO inhibitor, which will help elevate chemicals in your brain that can lift depression. It also is useful in Alzheimer's in particular, partly because it helps the mitochondria work better, but also it inhibits an enzyme that it's an anticholinerginase inhibitor, I believe, that's going to help raise acetylcholine levels, which is a neurotransmitter in people with Alzheimer's disease, and can help with that. So there's a lot of good things with methylene blue. Okay, ivermectin. The only role that I believe it plays in tick-borne infections is it may have the ability to kill Babesia. We have one scientific study that tells us that, okay? We have 0 scientific studies that tell us it kills Borrelia, Bartonella, or any of the other tick-borne infections. And I do admit some people say they feel better on ivermectin, but probably what's going on is ivermectin is a strong cytokine inhibitor. So the main reason people in tick-borne infections may feel better on ivermectin is not that it's germ killing, except maybe in Babesia, but rather it's an anti-inflammatory through its cytokine actions. Okay, all right. So I don't recommend it. I'll put it that way. Red light therapy, I think, is useful as an anti-inflammatory, particularly related to exercise, and may help your mitochondria work better. In terms of whether it is useful in tick-borne infections or not, I honestly don't know. I haven't added in my practice, but that's in theory what it could do. And I don't think you'd hurt yourself trying it. I mean, especially if you've got a local place you can go and give it a try. But that's what it is, anti-cytokine and going to help your mitochondria work better. It's really big in the world of exercise, people that exercise, also in anti-aging medicine, longevity medicine, especially because of its mitochondria promoting effects. Okay, all right. Hyperbaric oxygen. We used to think years ago that it might be the oxygen forced into your tissues under high pressure would kill germs, but it doesn't seem to work that well. To be honest, a lot of us were trying it 10, 15 years ago and it did nothing. But what it can, there's two reasons to use it. One is if you've got somebody, you've tried doing all kinds of mitochondria repair work with like the ATP 360 I talk about and glutathione. So you try to repair the injury. Hyperbaric oxygen can help mitochondria function too when it's really stuck by forcing oxygen into the mitochondria. All right. The second thing that hyperbaric oxygen can be useful for is helping your injured brain repair itself. So there's a phenomenon called neuroplasticity where injured nerve cells that lose connections with other functioning nerves, those functioning nerves will reconnect with the injured nerves, causing them to start working again. And so that's called neuroplasticity, and hyperbaric oxygen seems to be helpful in that situation. So in the world of tick-borne infections, if I'm like a year and a half, 2 years into infection, and I've got somebody whose brain still is not turning on, I might consider a trial of 20 to 40 dives of hyperbaric oxygen in those situations. It used to be we thought we had to go to 2.4 atmospheres, which is what a hard shell will do. More recent studies are telling us probably 1.2 to 1.5 atmospheres per dive. That's what a soft tank does. So that's the kind of thing you can even buy for your home if you need to, too. They're not cheap, but that is something you can do for your home. Okay. You're welcome. All right. Let's see. Did anyone else have a comment there about that? All right. Okay, Aliska, let's see. Hello. As per your advice earlier to my daughter started adding Japanese knotweed. I need to go low and slow, so we are at 5 drops per day at the moment. When I tried to go off the antibiotics, she developed fever and all symptoms came back. You also recommend methylene blue for her. However, being in Europe, I can't get to it. I tried. What would you suggest instead of methylene blue for her? Per your advice, she's been on cryptolepis, Japanese knotweed, and then later on methylene blue plus fluconazole. So, Aliska, is she actually on the fluconazole now or not?
She is, yes.
Okay. So if I understand this correctly, her current regimen is Japanese knotweed, cryptolepis, and the fluconazole then. Is that correct?
No, because so after you suggested it before Christmas, I went off the antibiotics, but I didn't know that I need to be doing it low and slow. So I quit cold turkey and started Japanese knotweed, but it just didn't go well. So then it was like after a week. So then I added everything back in because I was scared because there's literally nobody to help me here. And if I went to doctors and told them that, hey, she's on 3 different antibiotics, they would probably really not understand. So I put her back on and then I started to go really slow and low. So I started with 1/4 of a drop. And I was able to increase that by 1 drop a week. That's why we are actually at 5 drops of Japanese knotweed currently. Now she is still on her 3 different antibiotics and the Japanese knotweed, and she's taking fluconazole, which actually is no problem for her. She's tolerating that, no bother. But then I was waiting until I can be on full Japanese knotweed to actually add cryptolepis. But then in the meanwhile, I was searching for the methylene blue. But because I'm actually within the European Union, the European Union apparently does have a law against the methylene blue, and I wasn't able to get in the pharmacies, in the compounded pharmacies. I'm not able to get to it, and because it is a child, I really don't want to be just getting any of the internet. So I wanted to ask, how should I tweak the protocol later on if I'm most likely not going to be able to get the methylene blue?
Okay, so to clarify, because I just want to make sure. So you want to know what else you could add in instead of methylene blue in the future. Is that?
Yes, yes.
Okay. And right now she is on. I'm trying to make sure I understand what she's on right now.
She's on 3 antibiotics that I will be trying to get rid of slowly.
And
now.
What is she on herbally?
She's on 5 drops of Japanese knotweed and the fluconazole.
Okay. I would probably just go with the cryptolepis then. So, I would instead of, since you can't get methylene blue, go ahead and start working in the cryptolepis.
Okay.
Okay. All right. And so again, the methylene blue is good for growing and persister, Borrelia, and Bartonella. Cryptolepis also will go after growing and persister, Bartonella, and Borrelia. The only thing it's not going to do that methylene blue does for Bartonella is it's not a biofilm buster. So if Bartonella is her concern, you may still want to consider adding in something to break up fibrin, with fibrin nest, and biofilms. Okay, and we talked about that earlier with Jim today. So you can look at like a lumbric and a biodisrupt. But your crypto will be a good substitute for the killing aspects of the methylene blue, and I find it stronger than the Japanese knotweed at doing all that.
Okay. Great. Thank you very much.
Okay. Yep. Good luck. Yep.
Thank you.
All right. Anyone have a question there about that? All right. Let's keep moving on. All right. Let's see, Melissa, how do you differentiate between a drug reaction, other health issues, or severe HERC reaction, especially if there were minimal HERCs or sensitivity prior? That is a tough one. Melissa, it's more of an art. So I'm just going to tell you my general idea is, so again, what a HERCs is you have increased killing. The immune system sees the dead bug parts and makes more cytokines, okay? Keep in mind, in long COVID and tick-borne infections and mold toxicity, most of your underlying symptoms are excess cytokine symptoms, meaning the immune system reacting to these problems makes too many cytokines, and too many cytokines make it so you can think, hurt all over, et cetera, okay? So a HERCs is always some kind of worsening that happens, usually within a day or two after you either start a new germ killer or you increase the dose of that germ killer, all right? That's usually suggests a HERCs going on. But typically, that worsening will start to dissipate by a week or two. If it does not, then you start wondering, oh, okay, that's one part. Second part is, a HERCs will give you worsening of your underlying symptoms. Because again, your underlying symptoms are cytokine related, and a HERCs is another cause of excess cytokines. Okay, so a HERCs is a worsening that occurs near the time you either increased your antibiotic dose, herbal antibiotics to, or you added a new germ killer. Okay, all right. Now, a side effect is usually something that looks different than your underlying symptoms. It's not always clear though, but it usually will look different. Like I started itching all over the place when I added this one thing in, or I got daily headaches that were throbbing in the front of my head, and that was not part of my underlying symptoms. That's a side effect, okay? So those are just some, I don't have a clean answer for you, but those are the things I'm going to consider with my patients when I'm trying to figure it out.
Okay, so if it takes about a week for that reaction to come in and kind of sudden onset fevers when there previously necessarily weren't fevers, that would be a greater sign of a reaction, I assume. I'm sorry, like a
Probably reaction, because
the
there
medicine.
is another thing which is called a drug fever, which is is more of an immune related problem to the immune system reacting against the drug. Those kind of reactions will sometimes take a few days, maybe 5 days, 6 days to build up, basically.
Okay, sounds great. So that was with rifabutin. I was previously on rifampin with no problems, which I guess is okay. But would you recommend, like we said before, the methylene blue as a substitute for the rifabutin?
Yeah, yeah.
Okay.
And if that developed, if I had a patient that developed temperature, which was not part of their original symptomology with their tick-borne infections on rifabutin, I would call that a drug fever.
Okay, great. Thank you for your clarity.
Okay. All right. Yeah. Good luck to you.
Thanks.
Hello, Mary. Mary, I didn't realize you were here. There you are. I do now realize you're here. I see you. Let's see. I need guidance with lumbar kinase. I know every patient is different. I am with a physician that is not into treating patients with lumbar kinase. Oh, Dan. Anyhow,
You know it.
I know him. Oh, Dan. Anyhow, he says that just because something is making you feel worse doesn't necessarily mean you will feel better down the road. I have been on tefenaquine for almost a year and added the lumbar kinase in November. The herxing has gotten very bad, so I have now backed off for 5 days. I need to know how to reapproach taking lumbar kinase so I can get through this treatment. Thank you. Okay. So, and then I'll say it again. Oh, Dan. Anyhow.
He's actually mad. And when I bring up lumbar kinase, he gets very flustered.
No, I can see it. You know, the thing I like about Dr. Cameron, that's who we're talking about, is he's really good with his prescription antibiotics, but if there's anything out of the box of that area, he'll even say, I don't know about it. Go see a naturopath. So at least he's
Yes, he
willing
does.
to have you look into it. He's not totally discounting it, you know. So yeah, yeah.
Not a
Anyhow,
believer.
yeah, no, he's a good guy though. Anyhow, what I have done with my patients that have extreme killing as a result of adding in lumbar kinase is to try to find how frequently I can give it to them without blowing them apart and or reducing the dose so I don't blow them apart. Okay, so for instance, if you're really sensitive to lumbar kinase, I probably would not be doing it every day. I'd even look back at trying every 5th day. Find a frequency that you can tolerate, okay? And if that still is too much, you might, and you know, and then increase it as you can, okay? The other thing is open up the pill. You may have to divide that capsule in half or a quarter. Find out how much you can take that doesn't trip you up tremendously. And let's say it becomes a quarter pill. You know you can pretty much tolerate that. Then increase from every 5th day to every 4th day on a quarter pill. See if you can work up to a daily dose on a quarter pill as an example. Then start ramping the dose up from there. So it sounds like you're getting quite an effect from it. You just got to find the dose that doesn't blow you out of the water, basically.
Yes, but I did start out low. I started out low and I did work my way up, but I got to 1 tablet once a day, and now the herxing is really bad. You know, symptoms I've never had before. So
then back down. Your body may not need, you know, all of these doses that I recommend are for an average person that's not sensitive. Right? And the theory I have about people that are greatly sensitive to things in general, and this is my theory, okay, is that they are people that have a harder time detoxing these substances out. All right, so what we're interested in is, do you get enough in your blood to do whatever we want it to do? So do you get enough lumbar kinase in there to break up your fibrin? Do you get enough antibiotics in you to kill your germs? Okay, so there's a blood level we're interested in, okay? But what determines this blood level is how much do you take to get it up there, okay? And the other thing that determines this blood level is how quickly does your body break it down and clean it out? If you are a low detoxer of this substance, you don't need to put as much in.
Okay.
So what I try to advise my patients to do that they're sensitive to something is don't get hung up on the target dose.
Okay.
Get hung up on a dose that's going to work for you.
Okay.
Yeah. Does that make sense?
Yes, it does. It's just, you know, it's very difficult right now trying to, it wasn't at first, but now it's difficult. Very.
Yeah. I got it.
So
All right.
just, I want to add it back in again, but, you know, I guess I'll have to do it maybe every other day.
Sure. Sure.
Yeah.
Sure.
I'll never get to 2, I don't think.
You may not need to.
Okay.
Again, that's what I'm trying to say. Is I wouldn't get so hung up on
Right.
the goal of reaching twice. I might just get hung up on being able to tolerate 3/4 pill a day and go forward. from
Okay.
there. Yeah.
Okay. Yes. Thank you very much.
All right, Mary. Good luck. All right, everyone. I know there's tons more questions here, but as you know, there's one of me. And I talk a lot too. But anyhow, that's it for today. I will be with you all next week, but we will have an 6 o'clock Central Standard Time one later today. When I post up the video, I will also set up the next series of webinars so you can sign up for next week as well too. Okay. And it'll probably be mid-afternoon before I get this all out, maybe even later. I have to wait for the Zoom to produce the video, and then I've got to do some edits on it and some fixing from there. Okay? All right. Goodbye, everyone.
Thank you very much, Dr. Ross. Thank you.
You're welcome. Bye-bye.